So that would be the only thing that probably would explain why it's not consistently reading the same FiO2 in different areas inside of the tent. Okay, and so as we move on here, we know that when it comes to taking a blood gas sample, it's all about determining acid-base status, ventilation, and oxygenation. So when it comes to the newborn, we could get blood from their umbilical artery or just one of their regular arteries, like the radial artery, for instance. We could do heel sticks, which is going to be our capillary sampling. And then if they have a pulmonary artery catheter inserted, then we could take blood from the distal port and run it for mixed venous oxygenation. So when it comes to the blood gas, it's really going to be either an ABG, VBG, or CBG. Now, of course, with the venous blood gas, all you're going to be really concerned about is the pH. So the pH and the CO2 are going to be pretty much the same as if it were the arterial blood gas sample. But as we know, the PO2 is going to be more reflective of not necessarily mixed venous, but it's just going to be venous O2. And then the capillary blood gas, or CBG, we're looking at it mostly for the pH. And we know that capillary blood, the PO2 is going to be low because the O2 has already been delivered to the tissues. But either way, it's all about trying to ensure that the baby is adequately ventilating, the baby has a normal pH, and that oxygenation is adequate. So with this report right here, this is just a breakdown of what you would expect to see on just like a standard typical blood gas report. And this is the one that's just probably generated by the machine, like a little, sometimes it's just like a little ticket. The ticket that will be similar to like at a cash register, as it's kind of like giving you the receipt. It kind of gives you this little breakdown, or it could be printed on an actual document. Just have to send it to the printer and it'll give you all your information. And then it'll usually be categorized as far as measured values, calculated values, and then anything that you have to enter into the computer. And then this temp correction section here. So this temp correction, the question is there any value to it? So what happens is when you take your ABG sample, the first thing that the analyzer will do is warm it to, say, like standard temperature. So that would take care of any problems as if you had the blood on ice for a long time. So now it'll warm it up to what's considered to be normal body temperature, and then it'll do its analysis. Now, if your baby was running a fever, then if you entered in the right temperature into the analyzer, it's going to give you now two different sets of values. It's going to give you what it would have been if you hadn't temp corrected that sample, and then what it would be based on the fact that the baby's running a fever. And as you see, it makes a pretty significant difference on what you're going to be seeing on your report. So some places are not really going to be that concerned about doing the temp corrected, and then other places are going to expect you to always do a temp corrected for all patients, not just babies, but even adults. And this is mostly if you are running your samples yourself, like in your own department. If you're sending it to the lab, who knows what they're doing? I mean, you could probably include in the information that the temperature is elevated and what it is exactly, and then it'll be up to the lab technician, I guess, to do the correction if they're going to do it. But I don't know what their policies and protocols are for that. But at least as far as the RT department, this is probably something they would like for you to follow. And then this other question here. So all your calculated data are going to be based on your measured values. So the analyzer is using these 3 electrodes, the SANS electrode, SANS, find another color here. So SANS and then Severinghaus for the CO2, and then the Clark electrode. And then from there, it's going to be able to calculate the bicarb, base excess, SaO2, A gradient, and things like that. So which one of these will be useful? Well, they would all be pretty useful. And as long as the electrodes are working properly and they give you the right measured values, then your calculated data should be pretty accurate as well. But of course, if one of the electrodes is not working, then it's going to throw everything else off as far as the calculations, so your calculated value. Now, let me I have some room here. So let me just write, just as a reminder, so I'm writing here quality assurance, and this is more so operator assurance. So that way, when you collect your sample and you run it through the analyzer, you should be getting your accurate results. So with bubbles, we know that if you don't get up all the bubbles, then it's going to throw off all of your values. But what exactly is going to happen? So with bubbles in the sample itself, if this is a room air sample, then that means that you've got an air bubble that's now in contact with your blood gas sample. And if your PaO2 in the blood gas sample was, say it was 65, the PaO2 inside of the air bubble is about 160, because that's how much O2 is in the air that we're breathing. So if you got a PaO2 inside the bubble of 160-ish, and then your ABG's PaO2 was only about 65, then we know that those two pressures are going to try to equilibrate with each other, which would mean that your sample PaO2 is going to start increasing. I'm going to write here, room air sample So your room air sample is going to be affected. So that means that your PaO2 will end up going higher than normal. And then Dalton's law would say that if the PaO2 is increasing, then the CO2 is going to start to decrease. So your PaCO2 will start to be decreasing lower than what it should be in that sample. And then, of course, the acid base is going to depend on, say, like the CO2. So then if you got less CO2, then your pH will start to go up. So just because of one air bubble, you can completely change the entire results that you would have normally had. So then you could, of course, have an ABG that would look like, say, like it would look like a respiratory alkalosis when really it wasn't. And it was all because of the air bubble that wasn't taken care of beforehand. So then another problem that we could have would be so now we know we place the sample in an ice slush or an ice bath, or just a bag with some ice and a little bit of water. And that's so that you can slow down the metabolism. Those cells that you just collected in that ABG sample, so all those red blood cells, they are still active for a little while. So there's still metabolism that's taking place inside of the ABG syringe. And if you don't slow down that metabolism, then we know that the cells are going to continue to consume oxygen and they're going to produce CO2. So in an unionized sample, metabolism is still active, which means that your PaO2 in that blood sample is going to start to drop because of the fact that those red blood cells are still consuming the oxygen inside of your syringe. And there's no more access to oxygen once it's inside the syringe. So this is the only place it's going to be able to draw from or collect from. So your PaO2 starts to decrease. And then again, Dalton's law would say that the CO2 will start to increase. And now your pH would come across as acidic. So those are like two of the things that we could usually regulate ourselves to make sure that we don't end up with numbers that are inaccurate. And then once upon a time, they used to have to take their they'd have to take their ABG syringes because they were made out of glass, and they would have to aspirate heparin into the syringe and coat the inside of the syringe. So essentially aspirate some heparin inside of that syringe and then evacuate it out. And inside there's still a thin layer of heparin, and then they would get their ABG sample after that. And it depended on the type of heparin that they used. Apparently, one type of heparin could cause the pH to become acidic, and another kind could cause it to be alkalotic. I'm not sure how all of that really works, but today we don't have to worry about that because your ABG syringes are prepared in advance with just a little speck or a little flake of heparin that will dissolve once the blood mixes with it. And that way you won't have to worry about too much heparin inside the syringe, or maybe not enough heparin inside the syringe because it's already been pre-measured for you. Okay, and so now when it comes to babies, so there's options that we have when we have to say do an ABG puncture on a little one. You could use like a numbing type of agent, like they say, like an anesthetic cream. I have never seen this being used ever, but it's an option that you could do. Or you could do just straight up lidocaine and inject it into the skin before you do your sample. But the only problem with using lidocaine intradermal is that you've got to stick the child twice now. So the first time to get the lidocaine in, and then the second time, if it's numb, they won't necessarily be uncomfortable. They probably won't feel the needle, but it's still 2 needle sticks. And I really haven't seen anyone really doing that. Now with adults, yes, occasionally, you may want to consider doing the lidocaine intradermal injection for someone who's extremely, extremely sensitive to pain. But then this second bullet point here, for sure, we did this all the time. We use just plain old sugar. Pharmacy would supply just like many, many, many little syringes full of sucrose, and we kept it at each baby's bedside, so that way, anytime we had to do something that was going to be noxious or considered painful, like any kind of like blood stick or anything for that matter that's going to probably be painful for that baby, just take a syringe of that sucrose and just give them a few drops of that on the tongue, and then that acts as an anesthetic. Now, as far as your sampling, you don't really want to go brachially, and you definitely don't want to go femoral. So your best bet is to just stick with like the radial artery, or you could do the foot, like the dorsalis pedis or the posterior tibial. And then even in the very, very small babies, like the very micro preemies and so forth, you could even insert a catheter or take a sample of arterial blood from the temporal artery. All right, so the modified Allen's test. Now, this test has been so confusing over the years, because the way that people will interpret how the test is supposed to be done, it just seems to be up to that person's interpretation. And when you say negative Allen's test versus positive Allen's test, that's also, it all depends on, I guess, the place that you're working and what they expect you to see in a positive test or a negative test. But just a little bit of history, we know that this guy, Van Nuys Allen, was the one who came up with it. And then a few years after that, another guy came along and modified it, because the way that Van Nuys originally intended for this test to be done, it was a little bit time consuming, and it pretty much got simplified by Wright, and this is the test that we're doing today. So any type of area where there's going to be some collateral circulation, we want to test to make sure that there is going to be collateral circulation. And that means that even on the foot, if you're going to try to get sample blood from the dorsalis pedis, you could treat the posterior tibial artery almost like the ulnar artery in the arm, and you could occlude it and then uninclude it to see what happens. Okay, and then this picture right here is just to show that if you were to cause some damage, of course, to the radial artery, then you've got your ulnar artery as a backup. But then if you were to, say, cause problems with your brachial artery, it depends on exactly where the problem is. So if you cause a problem right here, then there's still a backup. As you see, there's a branch here where the blood can still make its way down into the hand, to the lower arm and the hand. And the same would go for here. You've got another branch as well. So as we know, there's typically no way of trying to check for collateral circulation with the brachial artery. But again, when you're dealing with babies, that's just not an area that you're going to want to try to puncture anyway. Now, as far as the procedure, if you haven't already had a chance to work with a butterfly syringe, this will be something that you will have to, a butterfly needle, this will be something that you would have to get really familiar with and use as your means of collecting your blood sample. Now, this also will benefit a lot of adults who have very small vessels, like very, very small arteries. You may have to, instead of just using your ABG prepared syringe, you may have to grab one of these butterfly needles and connect it to your syringe. So this box 8.2 is from the chapter, and it just kind of goes through, these are some of the basic items that you're going to need in order to do a puncture with, say, like with a baby. And this is really not anything out of the ordinary, except for maybe the fact that you've got this little 25 gauge butterfly syringe or needle. Okay. So then the procedure, this is just like best practice, and it could slightly deviate depending on exactly where you're trying to get your sample, and of course what you're doing and what type of sample that you're collecting. But always follow our standard universal precautions, and then do your Allen's test. But once you find a good pulse, just to check, make sure there's collateral circulation. Step 4, you will have to, a lot of times, let's say this is in the ER, you're going to have to get your parents involved, or whoever the caregiver is, to help restrain these kids, because, as you know, children in general are not going to be the most cooperative, and a sick child is going to be even less likely cooperative. And then, of course, you prepare your site. Usually alcohol is good enough. I mean, I would be cautious of using the iodine, because you just never know who's got an allergy to iodine. And then the process of just trying to find the best place to insert, just like where's the pulse the strongest. And then here we are using our butterfly syringe. And it's the same approach. You're using like a 35 to 45 degree angle. And there's a bevel on this needle as well. So you're always going to make sure the bevel is facing upstream, like where the blood is coming from. And then you get your sample. And of course, with babies, you don't need that much. These analyzers are pretty good. They don't really need a whole lot of blood to analyze. But you always want to get, say that your policy is to always collect a 0.5 milliliter of blood. The analyzer is probably, when you tell it that this is going to be like for a baby, then it's probably only going to take maybe half of that. Or you may want to get just a little more, just in case something happens to the first sample. And then, of course, the last step is to make sure you get rid of any bubbles and get everything processed. I mean, as far as like the information you need to tag the sample with, as far as what was it drawn on, and if you check the pulse ox, what was the saturation from the pulse ox, and of course the correct patient as well, and the time and date. Now, contraindications, and if the Allen's test, if the Allen's test was negative, then we know that you should try the other site, or you should try the other side. And extremities are still kind of white or blanched looking. That could be a perfusion issue that's going on. So you definitely don't want to insert another needle into an area that looks like it still hasn't really regained proper perfusion yet. So the color really hasn't come back yet. And then any kind of shunt, just stay away. Don't even bother trying. So it says here, distal to or through the surgical shunt. So I would just translate that to say, if there's a shunt on the right arm, don't even think about it. And the same will go for the left arm. Don't even think about it. And then 4 is obvious. If it looks to be infected, then you're going to stay away from that area. And then if you know the history, if there's been something written about the patient having some type of peripheral vascular disease or something of that nature, then that's also a contraindication. Now, if you didn't hold pressure long enough with any type of arterial puncture, then we know that there's always the potential of a hematoma developing, because just because the skin has formed a clot, that area where the needle went in, doesn't necessarily mean that the artery has formed a clot yet. So there's two clots that have got to form for bleeding to stop completely. And again, when you're applying pressure to the skin, that'll probably be the first place the clot forms. And then eventually the artery itself will form a clot where it was punctured. And then the same as, your standard precautions, you're trying to be as clean as possible to minimize any potential introduction of organisms to cause infection. And then some patients who have to get multiple sticks, they get fibrotic tissue in that area. And that's something that we really want to try to avoid, is just sticking over and over and over again, especially if you got to do like multiple draws. And then laceration, meaning that these syringes, because they're cut with the bevel on the end, they're extremely sharp. And you could literally slice the vessel. If you're having to go in and reposition and go back in and reposition and go back in, that's essentially just sawing through the vessel. And it could cause some extensive damage from that. And then the nerves, you never know where exactly those nerves are that are running right alongside of the vessels, but you know they're there. So that just means that a lot of times by accident, you can cause nerve damage by going in with your syringe. And then, of course, any kind of like thrombosis, clotting is always of a concern as well. Now, a capillary blood gas sampling. Let's say that you maybe could not get your blood, or you could not get proper collateral circulation with your right radial or your left radial. And you're not going to go brachial, and you're not going to go femoral. So then, let's say you couldn't even do dorsalis pedis or dorsalis tibia. Then maybe you could just do a heel stick, which would be capillary blood. And if you do a capillary blood sample, you just go into it knowing that the pH and the CO2 are going to be close to what they would have been in the arterial sample, but the PO2 is going to be worthless. I mean, it's not going to tell you anything about oxygenation. So that's why it says here that if you are concerned about oxygenation, a CBG is not going to help you assess what's going on. And then because of the fact that you're taking a sample of blood that's considered to be capillary, then a lot of things can affect the outcome, meaning that if your patient is hypotensive, then you may have a hard time just getting the blood to drip from the site. So you're going to puncture the heel, and then you would expect the puncture site to start to bleed a little bit. And if they've got low blood pressure, then it may not happen. And then you're going to now probably get desperate and try to force the blood out. And then that's going to lead to problems. So I'll put this picture here just to kind of show you that here's like a standard, here's your tissue, here's an arterial, capillary, venial, etc. But then notice that your lymphatic system is integrated throughout that entire system. So a lot of times if you're squeezing too hard on that site or too hard on that heel, what you're doing is you're now forcing lymph material out, and it's going to get mixed in with your blood. And if that happens, that's going to change your pH. And often what happens is if your pH ends up being acidic, It's probably because you squeezed too hard, and the baby's pH probably really wasn't that acidic, or probably wasn't even acidic to begin with. But because you got desperate and you started really squeezing down on that heel, then you kind of created the problem yourself. Same would go for hypothermia. If there's hypothermia, blood is being automatically shifted from the peripheral to the central. And you're going to have a hard time getting a sample in that situation. You could try to heat up that area to try to get some perfusion going again, but this all depends on just how hypothermic the patient is as far as if you're going to be successful in getting anything. And again, the same goes for hypovolemia. So hypotension and hypovolemia can go hand in hand because, if your patient's dehydrated, then it's going to be a challenge to try to get a capillary blood sample in a lot of cases. So now, when it comes to doing your heel stick, then there are areas that we have to stay away from, and then there's just this zone that we focus on. So first, don't puncture the posterior heel curvature. And that would mean like literally the back of the heel. You don't want to stick a needle there or stick a little lancet there and try to get your sample. As you can see, that can lead to possible bone problems for this child. And we definitely don't want to poke anywhere like in the middle of the heel either. So the area that we're really kind of focusing on is more or less like the side. Like this little area right here is good. This little area right here is good as well. And then we don't want to go probably any further than that. Okay, and of course, with newborns, we're never going to stick their fingers or toes ever. So your best bet is always just to focus on the heel, whether you're dealing with a brand new newborn or even like an older neonate. And then the previous sites, I've seen this happen before where, let's say that somebody had just collected a sample from the baby's foot, from the heel. And what they did was they left a dressing on it, and it was taped on, or they used a Band-Aid that kind of act as a pressure bandage or whatever. And then you go and you remove that dressing because more than likely the bleeding has stopped by now. And then once you remove the dressing, you might realize that, hey, it looks like there's a little bit of blood that's still there, and it looks like it may be dripping out. And you may be tempted to just kind of use that area again to get your new sample, but really don't. Just find another area and don't go back into a previous puncture site. Even if that site looks to be maybe not bleeding anymore, it's still probably pretty sore. And you gotta think about you being the baby and how would you feel if you got an area that was just punctured and it's still really, really, really sore, and then someone comes along and then just repunctures it all over again. Earlobes, you're not gonna do earlobes either. I mean, earlobes will be kind of considered a valid spot that you can choose if you're like an older person, like an adult. If the finger stick doesn't work like with an adult, then you could consider using the capillary blood from the earlobes. But again, with babies, don't. When it comes to CBG, I guess the golden practice rule would be just to focus on the heel stick, and that's it. And that way you want to worry about, is it acceptable or is it unacceptable? All right, so here's two pictures where they show, and again, I would just not use the finger at all. and just focus on using the foot. But if you were using, say, like the finger, then this is pretty much all you need to do. So just kind of think like someone who has to check their blood sugar. And then for the heel stick, the blue area, again, that's kind of like where we're going to want to focus. I would say that this blue area right here is way too far down. Because remember, this is a heel stick. So we're going to kind of like focus on this side and that side. And I would just probably take that area away. I would have like colored that all pink down there. Now, here are two examples of what to do and what not to do. So for the one on the left, this is a pretty bad technique. And this is probably what I was describing earlier. Someone is desperate to try to get that little area to start bleeding. The capillary tube itself is very small. It's very thin. It doesn't require a lot of blood, like maybe 2 to 3 drops of blood is plenty usually for these capillary tubes. But sometimes just trying to get 1 drop of blood is difficult. So it looks like this person is squeezing pretty hard because look how white or blanched this area of the foot looks. And then look how it's blanching over here. And then they're just trying to force blood out. But just remember, you're forcing out that lymph material as well with that blood. And I could see what happened. I can see exactly what happened. That corresponds to the first little bit of blood that they got, because with this capillary tubes use what's called capillary action, meaning that all you got to do is just touch the end of the tube with the blood and it'll automatically pull the blood in. So that's how plants get their water from the ground. Their roots are performing what's called like capillary action. So there's water around in the soil, and then the roots will essentially like pull in or suck in the water from the soil, and then it'll direct it all the way into the upper shoots of the plant and the leaves and everywhere else it needs to go. So this little capillary tube looks to be, they got a little bit of blood the first time they touched the tube to the heel, and then that little gap right there is saying that they probably, the blood didn't. I mean, there was no more bleeding going on, and then they got desperate. They started pushing or squeezing down on it to get more blood to flow. Now, if you do this correctly, so over here, this is our best technique. And if you notice, they're using a syringe. So this was like your syringe full of the sucrose. And you would do it, of course, before you stick the foot. But because they've got the syringe over the baby's mouth right now, I'm just thinking like maybe this was like another dose. Like they probably did it before, and then they're giving another dose just to make sure that while they're collecting this sample, and it's of course 2 different people. This is someone helping, and that way the baby should be okay and not really feel what's going on. So notice that all you're really doing is supporting the foot. You're not squeezing down on it or anything like that nature. And if this area is well perfused, once you take your there's like a little lancet, it's like a little automatic device that will, once you place it on the foot and press the button, it's like spring loaded. It's going to shoot out a tiny little needle and pull it back really quickly. So again, kind of like think like the person who has to check their blood sugar and they have to poke their finger with this little device that's got like a spring inside of it. So then once that happens, it should just start bleeding. And then you take your capillary tube and just touch the blood. And then the blood should just literally just start to get pulled in. And it will continue to get pulled in until your capillary tube is full, and then you're done. So when it works out well, it's very simple. It's very easy. And then when there's not good perfusion or there's some other challenges with the patient, then you may not get as much blood as you would like. So as far as the ABG analyzer, when you go into the analyzer and tell it that you're trying to run a CBG, not an ABG, the machine is definitely going to only take a small amount of blood. And this amount right here, even though the syringe or the capillary tube isn't full, this would probably still be plenty. So now, contraindications for doing our CBG or capillary blood. Again, if you need to see what's going on with oxygenation, the PaO2 in this, or it's going to not be called, it's not going to be PaO2, it's going to be PCO2. Your capillary oxygen levels are going to be always low, regardless of what your oxygenation status is. And then we don't do CBGs for someone who's especially unstable or someone who you need to follow up with on a regular basis. Now, in some nurseries, you will have lab having to come in each morning and get like maybe a CBG. But in other situations, it's just not recommended to use this form of sampling to monitor and see what's going on and make decisions and things like that. And if you got a newborn or a neonate who's not even a whole 24 hours old yet, we are definitely not going to be sticking their heels to try to get a capillary sample. For them, you got to get either a radial sample, you have to do a radial puncture, or the neonatologist will have to insert an umbilical artery into an umbilical artery catheter into one of the umbilical arteries. And we'll see an example of what that looks like in just a little while. So the decreased peripheral blood flow just means that you'll probably end up having to squeeze down on the heel to get the blood to start to flow. And that's not going to work out. Now, polycythemia, that's going to affect blood flow. And it's going to probably clot very quickly, even before it even has a chance to get pulled into your capillary tube in some cases. Or once it does get inside of your capillary tube, it'll start to clot very quickly. And then, of course, any area that looks to be not doing that well, whether it looks to be infected or if there is some swelling, then we know that we're not going to do a sample there. Calloused, if your baby has already started walking, then that's an automatic, no way am I going to try to get a capillary blood sample. As soon as the feet are now touching the ground, you're building up calluses. As we know, our heels are very rough for that reason, because if you wanted to always walk around barefoot, then that extra layer of callus tissue is going to protect your feet. So anytime that they have already started walking, then you're going to have to use another option to get blood. And this, of course, goes for someone who brings in their baby from the outside, like in an ER situation. If you were thinking, I could probably just get a CBG, the baby looks like he's still, I could get one from there. You just have to ask the parents, like, is he walking yet, or is she walking yet? If they say, yeah, they've been walking a little bit, then just forget about it. Now, again, because the CBG, the pH will usually be close to what the ABG would have been, and the CO2, but again, we know the PO2 is going to be worthless. It's not going to tell us anything. And that means you may try to make a major decision on therapy or making a change in your therapy based on the CBG, and that could be a problem. And then burns, I put this article here. It looks a little misleading. It looks like this happened at Lucille Packard, but it didn't. It happened in Texas. I think it was a nurse in Texas back in around 2013. I forgot to go back, well, 2014. I forgot to go back and verify which hospital it was. I think it was like a was it a St. Joseph's or something? Whatever facility it was, somewhere in Texas. I thought it was Philly at first, but I think it's Texas. So it looks like Lucille Packard, they took this article and they were using it like in one of their, this is definitely a concern and you want to be careful of what you're doing. So it's like using it as a learning opportunity. This is like a pretty bad, this is almost going down to the bone. So this is like a second degree burn here. And what happened was this was a nurse who wasn't a new nurse. She had been working for some years, but she was doing one of those shortcuts that can get you in trouble sometimes. And what she was doing was, I guess she couldn't find one of these little heel toe warmers or these little toe heel warmers, or maybe she was just too busy and didn't want to spend the time to go look for one. Because we try to keep these things very close by in the nursery. Like each bedside, there's a cart with drawers, and you just have to, usually like someone at the beginning of the shift or somebody, maybe someone toward the end of the shift is just always going to be checking to make sure that everything is stocked and you've got enough of everything that you need, especially these essential things like this. Let's see. I'm sorry, Jet, I didn't see the new message here until just now. No link. So there's no link for the presentation, today's presentation. Give me just a second here. Or was this the, there was no link for the your thoughts? I'm thinking that's probably what you were saying earlier. And you know what happened? I ended up sending that link to somebody else. So instead of the group chat, it went to somebody else's private box. So I pulled up the wrong thread here. So my fault. I'm just trying to just move along and not really. Yeah, so for your thoughts, but again, I'll be more careful the next time. Make sure that I'm taking everyone's, yeah, really. And everyone's been sending me private messages, and I just grabbed one of those by mistake, I think. So, yeah, so what was I about to do just a while ago?
Tawa yung ano, nagagalit si Christian. Pangilinan.
Okay, so yeah, I was saying that your nursery, you're usually pretty stocked and everything is usually within reach. Everything is like right there at the bedside usually. And then if there's something you need to go get from the other area, the supply area usually isn't that far away either. It's like each nursery is going to have their own supply area that's usually really close to the patient care area. So I'm just like guessing, maybe this nurse didn't have the heel warmer available or just didn't want to walk to where she had to walk to get one. So she used the old trick that I guess that she learned way back, is just to take a diaper and wet the diaper and then place the diaper in the microwave and heat it up that way. I've seen this happen before. I've seen nurses do this at the bedside before, where they would take this little diaper, heat it, and then wrap it around the foot. And I think the ones who would do that would be doing it mostly because they felt that the diaper was a little bit more effective than one of these little heel warmers that can only do so much. But the problem with the diaper is the technology. It was not technology. The way they make those diapers, that foam material, that gel-like material that they place inside the diaper to absorb all of the moisture and what Pampers will say that guarantee no leaks, and Huggies will say definitely no leaks. And it really comes down to how much of this like gel material that they're using. And that gel material inside the microwave gets to be super, super hot compared to the water itself, like the wet material, the wet cotton material, whatever, the absorbent material. And so that's what ended up burning this poor baby's foot. And I couldn't follow up to find out exactly what happened, but I don't know if this made it to court. But you know that the hospital had to have settled with the parents on this one because it made, as you see, it made news, it made headlines. And yeah, so this is just definitely one of those things. Your shortcuts will sometimes come back and really bite you. And just realize this is your license that's on the line. And you got to think about all times you got to be safe with your patient. And I don't see how she could even like live with herself after this. This is pretty bad. But I do think I remember seeing that there wasn't any extensive complications after this burn. But it could have been because just a little bit more, a little deeper, and it would have gotten down to the nerves and the bone. And it would have been, of course, your classic 3rd degree or 4th degree. So, of course, other complications, as we've seen before, if you're not being careful with keeping everything as clean as possible, you could introduce some type of infectious organism, scar tissue, and then long-term type of problems, the child could end up developing cellulitis on that leg. And this is like just some potential. I mean, not to say that every baby that gets capillary blood gas sampling is going to end up with cellulitis, but it's just something that could happen. And of course, damage to any of those nerves and the vessels themselves. And then with bleeding from the capillary area is not that bad because we're not thinking about a vessel that's under high pressure, like say an artery. An artery, your blood pressure is high, and then that's going to push the blood out even faster if it's still bleeding. But with your capillary, it'll bleed, but it's not going to be necessarily under force. But you got to think about someone who's vulnerable. You got a newborn, and this newborn may have either like a clotting problem, or they may have them on some kind of anticoagulant therapy. And which means that if you weren't being careful, then they could possibly bleed a little bit too much from that site, and that'll affect them as far as overall blood volume. Okay, so now the UAC, this is definitely something that the neonatologist will have to do. I'm not sure if the nurse practitioners are able to do this. I think it's still, most facilities are going to expect that the physician will do this. But either way, time is ticking. After the baby's been born, those vessels are still patent. And then over some time, it's going to become difficult to get anything inside of these vessels. But if you do get a catheter inside of either the vein or one of the arteries, then you could use that as your access port. You can get blood from those sources for at least about a week. And then after that, for infection control reasons, it'll have to be taken out. So of course, even right after birth, I've seen neonatologists struggle to try to get a catheter in one of these arteries. The vein is usually not a problem. As you see, just in perspective here, relationship, the vein compared to one of the umbilical arteries is huge. So their chances of getting a catheter inside of that is not that bad. But inside of one of those arteries, it could be a challenge. Okay, now as far as placement, let's say that they did get one inserted. And then if you notice, just from the picture right here, you've got two catheters. So this one is probably, can't really tell, but this is probably the artery, and then this is probably the vein. If we go back to like our standard 5 o'clock and 7 o'clock position, this is probably the 5 o'clock for this baby. Now, or maybe this is the 7 o'clock position for the baby, and that would have to be the vein, but it really won't matter because you can look on the x-ray and see which is which. So after they insert one of these, they have to get an x-ray. And depending on where the tip of this catheter should be, it'll depend on the facility and the physician as far as like how they feel about where they want it to stop. It could either be considered to be at the high position, which is like thoracic vertebrae T6 or somewhere from 6 to 8, or the tip of it could be a little bit lower, somewhere around lumbar 3 or 4. Now, this picture right here is just pretend that of course, they did this just so we can have a reference as far as what it would look like. This is the abdominal aorta. And here's our catheter that the physician inserted into the umbilicus. And then they inserted it and until the tip ends up resting here. So this is like at a high position, like the T6 or the T8 position. But again, it could have easily been a little bit lower based on like L3 or L4. Now, this is just representing the UAC, or the umbilical artery catheter that's been placed. And it'll show up as white because there's a radiopaque line, just like your ET tube, that radiopaque line on the ET tube. There's one on this catheter as well. So that way, when you look at your film, it'll show up as white. Now, on this side, you can't really see it, but you would have to use your imagination. You know that this has to be the inferior vena cava on this side. Blood is returning back to the right side of the heart via the inferior vena cava. So if you saw two radiopaque lines, one on this side and one on that side, then that would tell you that this baby has two catheters. They've inserted a UAC and they've inserted a UVC, which just stand for umbilical vein catheter. And again, it's not uncommon for them to have both, because with the UVC, this will be like that central line or central catheter we were talking about a few courses ago. This would be a really good resource for fluids, blood, give blood products if they need to give blood, to give vasopressors, to give antibiotic, anything. So this is a much better access to deliver medications and et cetera. And then with the UAC, now you can connect that to a transducer and measure blood pressure, real-time blood pressure, and then you can also collect ABG samples as you need to. The UVC could be connected to a transducer, and then that way you could now measure CVP, or right atrial pressure. Now, peripheral artery catheterization. Now, they call them sometimes PALs for short, PAL, which just stands for peripheral artery line. It's the same thing. A PAL and a peripheral artery catheter are the same thing. And they don't look like your standard arterial catheters that you would use like with an older, with an adult, but they serve the same purpose. Theirs look more almost like IVs, but they're in the artery instead of the vein. So once again, if you're going to insert, say like you, for whatever reason, let's say that the neonatologist did not have any luck with inserting this into the, and no, they didn't have any luck inserting a catheter into the umbilical artery. neither one of the arteries, they could get a catheter to thread through it. Now they would have to consider doing something like this if they want to be able to measure this baby's blood pressure and monitor that in real time, and then also to provide access for multiple blood samples. Mostly it will be the radial artery, but again, if you can't get good collateral circulation on either the radial arteries, you're going to have to now consider the foot, like maybe the dorsalis pedis or the tibial. And it says here that the brachial, temporal, femoral, rarely used. The other slide was warning you to just don't even think about using the brachial artery or the femoral artery. This is saying now, this is like going to have to be a decision made by the neonatologist. If they really are desperate to get access, then they would have to just weigh the risks and then take that risk and insert one of these catheters in, like, say, the brachial or the femoral. Now, let's take a 10-minute break, and then from there we can finish off the rest of this material. So let's 12:45, so we'll be back at 12:55.